not happen. Anyone else? If we don't get this book of paper, for all practical purposes, we're not here. We keep to the state for the end. If you slip out early, we're not taking your paper. I'm just saying. All right. Thank you.
Is this working? Can you hear me? Is it working? Now it might be working. All right, there we go. All right, everybody, I'm really excited to welcome you to the College of Science and the College of Behavioral, Social, and Health Sciences joint invited speaker for the 2024 TIDE Conference. And today it's my pleasure to introduce you all to Dr. Jyoti Pathak, who is coming to us from the Weill Cornell College of Medicine. This year's theme for our annual TIDE conference is When Artificial Intelligence Collides with Diversity, Equity, and Ethics. And so we're going to have some good information from Dr. Pathak's research, where he is interested in developing models of artificial intelligence and other types of informatics to address and make predictions for mental health problems and with patient records and other types of data. So I think we're going to learn quite a bit today about the use of AI and its pros and cons and the positive things that we can do in addressing issues of mental health.
Thank you so much. Is this on? Can people hear me? Okay, great. Thank you so much for the kind invitation. It's a pleasure to be here. I was telling Margaret that this is my first time in Clemson, and it's been a lovely day so far. So as the title suggests, I'm going to talk briefly about some of our work in use of AI in mental health research. Before we jump in, just a quick show of hands. How many of you have developed AI solutions? Developed algorithms, written software? Okay, there's one person at least. How many of you are using AI solutions for your day-to-day lives? Probably all of you have a cell phone, right? So there is some AI in your cell phone. So whether we like it or not, I think these types of technologies are becoming more and more prevalent in our day-to-day lives. And it's fair to say that these technologies are going to becoming even more prevalent when it comes to healthcare in general, but certainly in the space of mental health. So first, a few disclosures. I have a small startup company in New York where we do some work in this particular space. I'm not going to say anything that's relevant to this company. Also, I'll not be discussing any unlabeled or unapproved drugs or products. And last but not the least, I know this is an ethics gathering, but I'm not an ethicist. I'm a health services researcher with training in biomedical informatics and computer science. So I hope you will forgive me if I make statements as being a non-ethicist. Just to set the stage here very clearly, mental illness, as some of you may already recognize, is highly prevalent, not just in this country, but globally. By some estimates, 1 in 5 US adults suffer from mental illness during their lifetime, 1 in 20 from serious mental illness, such as schizophrenia or bipolar disorder. And the data on the left seems to suggest that conditions such as anxiety disorders are very prevalent. And we also see co-occurring substance use disorders and mental illness in the US population. And what you see on the data on the right, this is from National Alliance of Mental Illness, especially at the bottom part, where individuals who are multiracial as well as who identify themselves as LGBTQ have very high rates of some of these conditions. And so that's, of course, a big challenge for the health of our country. And in particularly, some of you may know our Surgeon General, Dr. Vivek Murthy. It has become one of his new missions that we are seeing increasing rates of mood disorders, and other mental illnesses in young people across the country. And the way they are trying to sort of approach this problem is that when we think about these conditions, it's clearly multifaceted, right? So it of course, your predisposition to these conditions is impacted by your age, your race, your ethnicity, your genetic makeup, your familial history. But there are lots of other factors that play a role, where you live, where you sleep, where do you work, what sort of environment you are engaged in, what are some of the societal factors that you are interfacing with. So it's clearly a problem that has many aspects above and beyond just the clinical markers that impact these conditions. So when we think about these sets of issues, there are sort of few problems that certainly we are working on, and many in this room are also thinking about it. And I've sort of highlighted some of these problems. I'm not going to go into a whole lot of details, but you can see at the very top, trying to sort of understand the etiology of these conditions, the underlying causes and risk factors for various diseases, thinking about ways by which can develop ways to early detection and diagnosis of patients. That's a huge issue. A lot of the mental illness related treatments, antidepressants and so on, there's always a trial and error. You try drug 1 first, it doesn't work. You go to drug 2, it doesn't work. You go to drug 3, it doesn't work. So trying to identify treatments that are ideally more effective, and preferably the very first time, is a huge unsolved problem. And then, of course, there are other issues around stigma and access. That's an area that we are very, very much working on and try to how to improve access to mental health care and mental health services. And that's quite frankly in space where I think AI and other techniques can really help. And then last but not the least, digital health has become a big component in providing mental health treatment and services to patients. Certainly during the pandemic, when things were all shut down, telemedicine and certainly telepsychiatry spiked up quite heavily. And some of you may have been familiar with chatbots and other mobile apps to provide access to therapists who are otherwise very hard to get into their care system. So again, these are some of the problems that we are interested in, and many in the field are. And as it turns out, according to my friend called ChatGPT, these are also important problems that where AI in particularly can really benefit the field of mental health research and clinical psychiatry. I'm not going to, again, go through the things here, but it sort of enumerates exactly the points that I said in the previous slide: early detection, diagnosis, personalized treatment plans, predictive analytics, virtual mental health assistance, focusing on multimodal data analysis, and of course, drug discovery and development. And one of the reasons why I would argue that there has been so much of interest in application of these tools in the field, certainly the broader field of medicine, but in mental health care, is because now we are at a stage where there is the possibility, and I emphasize the word possibility, of accessing robust multimodal data. So whether it's your patient medical records, which is where we do a lot of our work, whether it's publicly available survey data sets, whether it's familial history data, whether it's genomic data, we are trying to see a coalescence of multimodal data that's accessible on a single individual, on a group of individuals, on thousands and hundreds of thousands of patients, right? And that's where, again, the role for AI becomes very important, that with the development of these techniques, you have the opportunity to mine multiple layers, multiple modalities of data to derive different patterns and insights. And so that's where a lot of our work is, where the types of questions that we are interested in. Can we identify patients at risk of suicidal attempts? Can we look at individuals who might be at high risk of hospitalization due to a psychiatric emergency? Can we identify patients who might fail a particular antidepressant treatment, and as a result, instead of prescribing pill 1, I'm going to prescribe pill 2, right? Can we think about ways by which we can link not only their clinical data, but their social determinant or environmental health data sets, so that we can have much more better idea about different risk factors that might be triggering? So these are the types of questions that we are interested in, and most of our work is focused around depression, substance use, and suicide. And as you will see in the rest of the lecture here today, We primarily analyze patient health record data sets. These are large de-identified data sets up to 50 million plus individuals. So very, very large data sets. But we also have looked at social media, so Twitter and Reddit data sets. We have also looked at data from your Fitbit and other mobile health devices. And last but not the least, we've been working with a nationwide program called the All of Us Research Program, which allows us to access genomic information as well for some of these questions. So what are these questions? As I just mentioned, trying to look at depression risk prediction, trying to look at antidepressant prescription patterns, trying to understand symptoms of depression using social media data, trying to develop risk models for suicide or suicidal behavior. We have a study that we are working with the Veteran Health Administration where we're looking at veterans who served in the military and had have been diagnosed with chronic opioid, prescribed chronic opioid treatment, and now we are trying to understand their suicidal risk in that particular population where there is very high prevalence of PTSD, as an example. We have a national study where we are looking at severe mental illness like schizophrenia and individuals who are diagnosed with COVID-19. So there are lots of studies that are underway in our lab, but there are a couple of common themes that I hope you would also agree are relevant in this particular space. So first, we try to approach all of these questions from the point of view of the patient, right? I used to work at Mayo Clinic, and there was one mantra: it's the patient, it's the voice of the patient, it's the needs of the patient that matter. Nothing else matters, right? And I think we are sort of very much influenced by this notion here that when you are thinking about AI and machine learning and other techniques, you have to think about this life cycle where at the very left-hand side, you are in the knowledge generation phase where you are looking at large data sets, some of which could be from medical records, some of which could be from insurance claims, some of which could be from self-report surveys, and trying to derive insights which then have to be implemented within a care delivery setting. I could have the most fanciest AI software or AI tool, but if it does not help even one single patient, what's the point? So you have to think about ways by which you can bring those solutions to the patient care, to the physician, to the psychiatrist or other mental health provider, such that it impacts the care that they're delivering, it impacts the patient's outcome. And the last phase, of course, is to kind of evaluate what has been the impact, both clinical impact, financial impact, health system-wide impact. And in many ways, it sort of becomes a life cycle, right? It's like the phrase that people like to use here, it's called learning health system, where you are trying to generate evidence, you're implementing your insights, and then you are learning from the overall process. So a lot of the work that we do in our lab is governed by this overarching philosophy. And if I were to take one level deeper, it's very consistent with how the field of AI, and particularly AI in healthcare, is evolving, where your phase one activity is to develop these models and then try it out across multiple sites. So it's not sufficient enough for me if I create a machine learning model that works only in patients who come to Cornell. It should work for patients who come to Prisma. It should work for patients who go to UCLA. It should work for patients who go to Mayo Clinic. So different, diverse populations. So as a result, it's critical that when you're developing these solutions, you validate and revalidate and then again revalidate across different settings. When it comes to the phase two part, it is also important that we try to understand the risk-benefit analysis. What is the ROI there, right? Everybody is gung-ho about let's do AI and let's implement these AI tools. Okay, that's good. But is it really helping? And who is it helping? Or is it actually causing more harm? Because the first principles of medicine is to do no harm. So it's important that we keep this ROI component in mind. And then, of course, it's a repeated cycle where you're trying to understand the cost-benefit analysis, and then as needed, to refine the whole cycle. So I want you to keep this picture in mind, and the previous picture which I'm going to show, but I certainly wanted to keep this picture in mind as we sort of go through some of the studies that we are doing. In particularly, one area where we are doing a lot of work is in the space of perinatal mood and anxiety disorders. And this is work that has been, I've been fortunate to work with a lot of my colleagues here, all the way Yi Zhang on the left, who is a services researcher, to Alison Herman, who's a psychiatrist, Rochelle Jolie is an OB-GYN. And then we have 3 nurse practitioners, Megan Redding, Nat Benda, and Pooja Desai, who are working very much in terms of understanding implementation of these solutions and tools in our clinics in New York. So over the next, let's say maybe about 20 to 25 minutes, if you could please allow me to indulge you in some of the studies that we are working in this particular space. So again, just to set the context here, by some estimates, 1 in 7 women suffer from perinatal depression during their lifetime. And this is in the Western world. If you look at Asia, if you look at Africa, and also if you look at South American countries, the numbers are close to like 1 in 4, maybe even 1 in 5. So it's much more higher prevalence of these conditions. Unfortunately, as it turns out, that only half of these women are ever diagnosed. And as I'll show in the next slide, half of them get any form of treatment, right? So you lose a huge chunk of individuals who otherwise should be diagnosed in a timely fashion, should receive care in a timely fashion, and hopefully achieve good outcomes also in a timely fashion. But none of that happens. As a result, some studies have shown that now perinatal mood and anxiety disorders are the 2nd leading cause of postpartum deaths. The first cause is around preeclampsia and eclampsia and hemorrhage. But it is certainly a very concerning and unfortunate development. But furthermore, untreated PMADs cost up to $14 billion. And this is actually an older number. It's close to 15 now. $14 billion in taxpayer money for healthcare. And this is just in the US, right? There was a series of papers that came out. And if any of you are interested in this space, I'd certainly encourage you to go to this journal called Health Affairs. And just in this month's issue, the March-April issue of 2024, there's 7 or 8 different articles that are all geared towards this particular topic. And I'm just showing you 2 slides. This is not our work. So on the left-hand side, you can see that there is huge racial disparities in terms of actually who even is diagnosed. This is a study where they did, I think, looked at maybe just 7 states, so it's not entire US. And you could see that individuals who are from multiracial and multi-ethnic backgrounds, as well as women who are white, are more likely to be diagnosed than individuals from different racial and ethnic compositions. On the figure on the right-hand side, you see that when it comes to treatment, first of all, your y-axis is 50%, right? Only half of the women who are ever diagnosed on the left are getting any form of treatment. In this case, we're looking at only antidepressant prescriptions. I don't have data. We don't have data in this slide about behavioral psychotherapy and other cognitive behavioral therapies. But antidepressants, if you look at it, only half of them are getting any form of antidepressant prescriptions. But you see a huge jump, like around 2015, 2016, it started spiking up. It has leveled off still around 50%. And what has happened is that while first of all, it's a problematic situation that only less than half of patients are diagnosed, but around 2015, 2016, the American College of Obstetrics and Gynecology issued guidelines that we need to screen patients during pregnancy for these conditions. The US Preventative Task Force recommended guidelines. And as a result, hospitals and clinics started implementing these guidelines. The more you screen, the more likely you are able to identify patients. And as a result, the more likely you would offer treatment, right? So that's why we see this particular spike. But my problem is that there is still a huge gap, both in terms of diagnosis as well as in terms of treatment. So the question is, can we do something better, right? Now, as it turns out, some of the common risk factors for these conditions, as one would expect, past history of depression or anxiety, antenatal depression is a strong predictor of if you might have these conditions in your postpartum phase. But then there are a bunch of other social and environmental determinants that play a role, right? Lack of financial support and emotional support during that phase of your life is a big factor for someone who might be experiencing high levels of stress. Major life event, unemployment, miscarriage, COVID-19, These were all stress-inducing factors that impact the well-being of the mom at that time or to-be mom in the future, right? So epidemiological literature have sort of studied a lot of these conditions and have provided them as risk factors for perinatal mood and anxiety disorders. But the challenge that we encounter is that when it comes to actually diagnosing these conditions, there are lots of barriers in the current ecosystem, right? First of all, typically a lot of these screenings are done using this instrument. There's you can see it's a 10-item questionnaire called the Edinburgh Postnatal Depression Scale. And it's being administered when you are having a doctor visit, maybe even going for your prenatal visit. So in and of itself, one could argue that it's very stigma-inducing. Patients are not comfortable in filling out the form. Clinicians are not comfortable in actually administering this questionnaire because if someone screens positive, you have to do something, right? And if you have to do something, you have to find referral, you have to find ways to help the patient. And if you don't, you are potentially, you have liability issues. So there is this whole culture of don't ask, don't tell. Let's not even screen, why bother, right? So it clearly introduces a lot of stigma. And while, people can download a bunch of apps from Google Play and Apple App Store, and there's, by some estimates, about 5,000 plus apps related to mental health in these conditions. They're not evidence-based. There's no formal clinical trials. It's, someone app developer or a small startup company developing these solutions. And so as a result, it's very challenging as a practicing clinician to, first of all, do timely diagnoses, and then ideally offer personalized and timely interventions, right? So what we have been trying to do is to try to attack this problem. There's multiple issues here, as I'm sure you are hopefully grasping. But where we are coming at this problem is that can we actually use historical patient information to stratify individuals, right? And some sort of a low risk, medium risk, very high risk, some sort of a yellow or red, yellow, green kind of a risk stratum, so that we can then target them for appropriate intervention. So someone who is at low risk, they're perfectly fine. They can just proceed with their routine care, versus someone who is at a very active high risk of illness. Maybe they really need to see a psychiatrist tomorrow, right? So that's kind of how we are trying to approach here, is essentially to do risk stratify. And what I'm going to share in the next couple of slides is going to refer to this phase one, right? So that how can we use existing observational aggregate level data and develop this risk model that will allow us to tier patients into some kind of low, medium, high risk buckets, right? So the way we sort of approach this problem is, first of all, we looked at patients between the prime age of delivery. So anybody who was below the age of 18 and above the age of 45 were excluded from this study. And we essentially looked at all women who had childbirths and a diagnosis of depression within 12 months after delivery, right? So roughly 12 months of postpartum period. And our goal, again, here was to develop an AI model that will allow us to do this particular risk prediction. If you could please allow me to sort of walk you through this figure. So this is sort of a typical workflow of what happens when you want to develop these risk models, right? So you look at sort of very large data sets. So in this case, we looked at 3 years worth of data on roughly 17,000 women. And this was just done at Cornell. And you go through this process of experimenting with multiple different algorithms. Some of these names might be familiar to the audience here. Typically, a lot of these data sets have very, very large variables. So in our data set, we had over 700 different variables. It's not conceivable to make logical interpretations from these variables. You have to start shrinking the feature space, the matrix space. So you go through that process. And then you sort of look at questions around, is the model sensitive? Is the model specific? You look at different performance metrics that are relevant for the particular question that you're trying to answer, right? In our case, we looked at data, demographic information. We looked at all prior diagnoses. We looked at what medications patients have been prescribed prior to their childbirth. We looked at some markers that have also been associated, like body mass index. So individuals who are more obese or had high BMI were more likely to be diagnosed with postpartum depression. again from epidemiological literature. If you had higher rates of emergency department visits, more likely to be diagnosed. So again, we looked at a lot of these factors, and I'm just sharing a couple of data variables here. We looked at marital status, employment status, information that you could glean from these large medical record systems, right? And we developed some fancy math. I'm not going to bore you with that, but later on you can look up this paper. It's an approach called sequential forward selection strategy, which again allows us to shrink the feature vector, the feature matrix from very large variables to something that's more meaningful and manageable, right? So we applied all of these techniques, and the idea was that we wanted to identify the model which will give us the highest predictive performance to, again, tier patients into these different buckets, right? So what does some of our data look like? So first of all, if you look at the rightmost column, and this is again, our overall denominator was roughly about 17,000 or so patients after we apply inclusion-exclusion criteria. You see that in our data set, the number of individuals who were identified as true positives for postpartum depression was roughly 7%. If you look at epidemiological literature, at least in the US, the prevalence of postpartum depression is somewhere between 11 to 12%. So right here, we're missing half of the patients. Why? Because maybe they were never diagnosed. Remember, these are patients on whom we need to have a clinically confirmed diagnosis. If there was no diagnosis in your record, we are not going to capture you. So right there, we're losing half of the patients. So in and of itself, this model is biased, correct? Because it is only identifying those women and bucketing those women who have a diagnosis. Half of the patients have no diagnosis. So that's first issue. So the second things that you may observe, the things in bold, individuals who were on the later half of their childbirthing age, 35 and above, had higher pre-pregnancy BMI, had higher number of ED visits, were more likely to actually have a diagnosis of postpartum depression. But then if you look at our race breakdown, 65% of patients who had a diagnosis of postpartum depression were white. As we have seen in the literature before, this is consistent that more white women are going to get a diagnosis. But clearly, this also means that there are many women who are not getting an appropriate diagnosis. So if I develop the model only using Cornell data, it's going to perform perfectly well in patients who have a diagnosis and patients who are white. It's not going to perform in other individuals, and there are many in New York who come from different racial and ethnic backgrounds. And so that's something that is very important to keep in mind when you are creating these models. And I'll touch on this again as we go forward, which is that when you're developing a model in one system, this is just one system, it'll perform perhaps well in that system. You try to take it to a different system, it may perform, it may not perform. We don't know, right? And so that's something to keep in mind when we develop these solutions. But what was very interesting for us is that if you look at the x-axis here, sort of starting all the way from first trimester, second trimester, all the way up to childbirth, the y-axis shows the area under the curve, right? So that's essentially showing that how the model is performing. You can see our model performance is somewhere in the order of 0.91, 0.92, sort of hovering around 0.93-ish on average, right? So in other words, the model has a very high rate of identifying women who are at risk of postpartum depression and triaging as early as first trimester. So as a practicing clinician, that's very important for me, because if I know that here's a woman who is just pregnant, first trimester, but is at risk of developing postpartum depression 8 months from today, well, I can think about a lot of ways of intervening: psychotherapy, behavioral therapy, other kinds of potentially non-pharmacological interventions, which are perhaps more preventative in nature, right? And the patient is perhaps more willing to have a conversation and maybe try out some of these options, as opposed to waiting till after childbirth, and then it could potentially lead to a higher rate of acuity and severity, right? So this is a very important component for our study, that the model that we created was very much stable, right, across your pregnancy period, and provided strong performance as early as first trimester. What we also observed is that the risk factors that we saw in our data set, now remember, this is clinical data, right, that is being collected as part of clinical care. This is not epidemiological study where I send out a survey to you and you meticulously sit down with a cup of coffee and then fill the form and send it back, right? This is done during a busy clinical practice. There's a lot of missing information. There's a lot of bias. Many patients don't even seek care. However, the good news here is that the risk factors that we saw are very much consistent with what was reported in the literature, right? So prior history of mental illness, threatened miscarriage, number of ED visits, high BMI, and so on and so forth. These were all consistent with what has been reported in epidemiological studies. So in other words, what this indicates is that for those women who did get diagnosed and whom we did identify with a higher risk of PPD, we are indeed identifying the true positive patients, right? So as a result, it gives us some level of confidence that maybe, and I emphasize the word maybe this model is behaving truly the way it should behave, and how it can be, and it can then give us the option of trying to potentially implement within a health system at point of care, right? Because it's very consistent. The signals that we are seeing are very consistent with the literature. And so just to kind of summarize this part, this work that we did, and it's published a couple of years ago now, was one of the first studies in developing a risk model for postpartum depression using large EHR data sets. There's, of course, lots of limitations. First of all, it was done only using Cornell data at New York. So again, we don't know how it'll work in other data sets. Now, as it turns out, when it comes to mental health symptoms and conditions, a lot of this data is recorded in your physician encounter note, right? So you go and see your doctor. They say, how are you doing? How's your family? Are you eating well? Are you sleeping well? Right? They ask all of these questions, and it all goes in like an email. It's like a note. It's an encounter note. It all goes in an email and stored in your medical record system. That's a very useful piece of information. In this study, we did not look at it. We are now doing additional studies using large language models where we're processing this clinical text. But we have the belief that if we augment existing data with such clinical text information, we might actually bump up the performance even more. We'll have even higher confidence. But that's something that we are working on. But what I want to share with you next is that how we can take some of the work in terms of model development and actually try to bring it close to patient care, right? Because that's where kind of rubber meets the road. And that's where questions around implementation, questions around privacy, questions around ethics come into play. Because what we have done so far is all in de-identified data sets. It's large data sets, but it's completely de-identified data sets. But when you're taking these models and now saying, hey, Jane Doe, we think you are at risk of postpartum depression, 8 months from today. How should the patient react? How should the clinician share this information? How much do you trust the model that you are at 90% risk of postpartum depression today, right? So those are practical questions that we're trying to understand, which brings me to this phase 2, right? Where we are developing this computable clinical knowledge. We're trying to incorporate that within clinical care, and it raises questions. How should we deliver this information? When should it be delivered? What are support mechanisms that are in place? Should someone, let's say for heaven forbid, endorse suicidal thoughts? How do we manage these sorts of edge, but nonetheless very relevant cases? And that's where I see the problem that lies, right? That we are in this phase where I like to call this as the AI chasm, healthcare AI chasm, where on the left-hand side, we in academia, all of you in academia, right, we are very much interested in developing AI tools and AI algorithms, and we work very hard. I was just talking to the great doctor sitting here about how do we kind of implement these systems. We're working very hard to implement these solutions in clinical care systems. And it's not an easy problem. It's not an AI problem, to be quite honest. It's a systems problem. It's a people problem. Who is your beer buddy, right? Okay, grab that buddy and have a drink and then make a deal. It's that kind of issues. Not literally meaning, but yeah, that's where it goes. But then on the other hand, what we see in the industry is that health systems, including our own health system, are embracing vendor-developed AI solutions because they have a very shiny marketing team. They have a great product. And I would argue that a lot of these solutions are not well researched, not rigorously researched, right? So all of us in this room, and hopefully some of you as well, as you would try to pursue your career, your goal should be to closing this gap, right? What can we do that solutions that are developed in the academia see the light of implementation in clinical care versus how do we develop healthy academia industry partnerships? It's not us versus them. It's all of us together, industry and academia, and by that extension, government has a huge role to play in developing these tools. So how can we all work together in solving some of these questions? As it turns out, there are a lot of smart people, way more smarter than I, are thinking about these sets of issues, right? So you see a bunch of slides here, and there's some very nice papers, especially this new paper from Nature Medicine that just came out. In particularly, what has happened over the last maybe about 24 months, about roughly 2 years, is that there has been a strong coalition of thoughts. In particular, there are this consortium, there's called CHAI, which stands for Coalition for Health AI. There's another consortium at the bottom in blue called Trustworthy Responsible AI Network, where it's an industry, academia, government, non-for-profit, stakeholder groups, patient advocacy groups. They're all trying to sort of come together into the table. So far, they've come to the table. Nothing concrete has come out, at least to my understanding. But it's a start where they're having these discussions, tough discussions about how should we embrace AI, because it is happening. It is happening today, and it will continue to happen as we move forward. And there's a lot of work in this particular space. And the way, at least I think, that there are few ethical principles that should guide these sets of activities. It clearly guides our work at Cornell, right? Now, as a bit of disclaimer, I'm not an ethicist, right? So I've sort of taken some of the ideas from the WHO. This is a fantastic report if anyone is interested. But I firmly believe that these are the sets of principles that I think are relevant when it comes to AI for health. First, any of these tools should protect human well-being and safety. The first mantra for medical school is do no harm. We do not want AI systems to do harm. People are already, nobody goes to hospital for fun. You know, I haven't seen a patient. It's not like going to Central Park. So they're already in a difficult position. We do not want to induce more harm. So that's, I think, the number one rule here, and we don't want AI systems to do. Number two, I think it's absolutely important that when we are trying to bring these tools into our ecosystem, we protect the autonomy. We protect the autonomy of the patient. We protect the autonomy of the provider. We protect the autonomy of their families. We give choices, right? A particular patient, let's say, who refuses to accept an AI-based algorithm in their care should not be marginalized. A particular clinician who says, I don't trust this system, I'm not going to use them, should not be marginalized. People should have the autonomy of accepting or rejecting AI-based solutions. Number three, all of these tools, to the extent possible, should ensure transparency and explainability, right? I'm sure when you are driving and you use Google Maps or Waze, it says, take Route 1, and after 5 minutes, it just says take Route 2. Why? Because Route 1 is red and Route 2 is green. We just trust the system. Do you question Google Maps? Why are you asking me to go Route 1 or Route 2? I always take Route 1 every day. We never question the system. There is no transparency. We just trust it. We cannot make that assumption when it comes to healthcare AI. We need to understand how the model is behaving, what are the factors that are driving a particular risk score, and as a result, as model becomes more and more complicated, there's a huge new field of AI explainability that has sort of mushroomed, right? How do we make these models interpretable so that a particular busy clinician who's seeing maybe, 30 patients a day still has the actionable information at their finger sites? How do we make these models more interpretable, more explainable to humans? So I think that's a very important part. Foster responsibility and accountability. We were at the panel a couple of hours ago, earlier today, And I sort of brought this issue up, that as these systems are getting implemented, it can't be the Microsoft says, well, we implemented this, but it's your problem, if something bad happens. Or Hospital X says, well, we just took Microsoft's solution and we implemented, it's Microsoft's problem, right? Or the patient says, well, I was told to do this and I'm doing this, so I'm going to sue back. And so as a result, there is this whole issue of accountability that comes into play, right? And we need to foster an environment where multiple players are responsible and accountable as these systems get more and more widely adopted. Number 5, it's also equally important, as I have hopefully already convinced you, but I'm going to convince you even more, is to ensure that these tools are inclusive and are equitable, right? Again, tool that works in New York should also work in South Carolina, should also work in Idaho, should also work in LA. Different population composition, different patient composition, different clinical workflows. But ideally, to the extent possible, it's not feasible to run models on, 330 million US residents. That's just not going to happen, right? At least not anytime soon. But to the extent possible, these models should be much more inclusive. And last but not the least, AI is here. So we need to promote AI in a way that it's responsible and sustainable, which in turn implies that how do we train the next generation of the workforce, right? Maybe someone who is filing the prescription billing claims in the back office, that job may or may not exist 10 years from now. So how do we train the person to be well equipped in a new day and age of AI when the system is actually doing a lot of the work, right? Maybe there is a therapist who's providing care and a lot of their function is going to actually become virtual in nature so that there is an interface between an AI solution and the human therapist. So how do we provide training to the next generation of clinical psychology students? So I think these models should and would become sustainable. So I want you to, again, keep some of these elements in mind as we kind of go through. And the interesting part is that when I got the invitation to come and see you here, to be quite candid, I was not aware of your STAR decision-making model, right? And as it turns out, there is so much of parallels between what the WHO has created, and I'm sure there are similar models across the country about how do we think about questions of recognizing and identifying and developing solutions, testing, thinking about no harm test, respect test, and so on and so forth, and then making decisions in a way that are potentially beneficial to the patient and patient outcomes. So there's a lot of similarities in how these sorts of concepts are being developed. So with that, what I want to indulge you in the next couple of minutes is to sort of walk you through our postpartum depression work, where our goal is to actually implement this risk model that we have created within our medical record environment. And in this case, we are working with a commercial EMR vendor called Epic. They are one of the largest, I think, in the country and maybe in the world. And so in any event, our goal here is to develop this sort of information to, in this case, we are trying to do the pilot with 3 outpatient OB/GYN clinics where anytime someone comes for a prenatal visit, this type of information will be shared, right? So in this case, a particular patient is deemed as moderate risk for postpartum depression, sort of give some sort of a score range. We also mention about certain risk factors that might be driving the score. And we, to the extent possible, we make some recommendations of what the clinician could do, right? So at least it's a conversation that could happen between the clinician and the patient during their encounter, right? But the key point to come to this stage was a lot of brute work that we had to do, right? So going back to the different phases, the first step we had to spend a lot of time was to take our own model and see how it works across multiple different data sets. So here we started first with our own Cornell data. So our original model was developed pre-pandemic between 2015 through 18, just using Cornell data. In our next phase of the work, We took some data also before pre-pandemic, but also during pandemic. And I have a typo there. It's actually up till 2021. So a little bit of pre-pandemic, post-pandemic as well. And then we have, I'll show you in the next slide, we have established a research data network across New York City between 7 or 8 different health systems. And that includes patients not just from Cornell, but a lot of other health systems in and around the city. Some of them are very big players, Columbia University, Mount Sinai Health System, Montefiore, New York University, and so on. And so we have put together this, it's almost a 10 years worth of work that started back in 2013-14. We've put together this database of approximately 15 million New Yorkers, where some of the patients have data going back to 2003, right? So almost 20 years worth of data. And a lot of this data is linked to other information, insurance claims, patient-reported outcomes, social determinants, and so on and so forth. So yes, it is NYC. It is not Atlanta. It is not Clemson, but it is more than one health system, right? And so it gives us an opportunity to take the work that we have done in one health system, in one medical school, and then see how it performs across lots of other, by the way, very competing medical schools. We compete for NIH money. We compete for patient revenue. We compete for lots of things. But we were able to successfully put together this research network, and it's been phenomenal, right? So I'm going to kind of dive a little bit deeper. So please allow me to indulge you here. So we develop what are called as fairness measurements and metrics. I'm not going to go through all of the details, but broadly what we tried to do was to stress test the model, right? So again, if you remember my early comments, women who are white are more likely to get diagnosed for postpartum depression compared to non-white women. So we tried to see that what if we tune the model in a way that we provide equal probability to both white and non-white women? How will the model perform? We tune the model in a way that patients who should be labeled as true positive are actually labeled as negative, right? So we try to fool the model. Or we said that patients who are not supposed to have postpartum diagnosis, we injected noise and say, yes, you are postpartum diagnosed. You should have a postpartum diagnosis. So we did all these different permutations, combinations, right? And what we came up with were these different approaches, where we have the baseline original model, then we take the race variable out of the model, or we impute, over-impute patients with white race. We remove the race variable completely, retrain the model, sort of multiple different permutations and combinations. You can read some of this in our paper here. And we also condense the model in a way so that going from roughly about 600 or so variables, we have about 30 or so variables, right? So much more manageable that we thought were the highest risk predictors for postpartum depression. And we did these sets of experiments across these 3 data sets, right? So we, of course, started our baseline model just using Cornell data, 2015 to 18. But then we looked at 2019, 2020, and then finally the clinical research network. Right, so I want you to pay attention to the very first row. So you can see there, between 2019 and 2020, there's a huge jump in diagnosis of postpartum depression, right? So going from about roughly 10% to close to 14.5, so almost a 40% jump. And we have reasons to believe that this is the time of the pandemic when there was increased awareness between patients, increased awareness between clinicians. More people were being asked questions. How are you feeling? Did you have someone in your family who unfortunately passed away due to COVID? Or was someone hospitalized and is in the incubator due to COVID, right? So stress-inducing factors. And so as a result, we saw an uptick in overall diagnosis. That's not to mean that is continuing right now, but we certainly saw an uptick. But more importantly is the last column, where we saw that when we look at the larger network as a whole, our estimates of postpartum depression is much more closer to what's been reported in the literature, which is somewhere in the 11 to 12% range, right? So again, this is a reflection of what is the true prevalence, which you can only see when you're looking at multiple health systems, data sets from multiple institutions, much more larger data sets. So that's the first observation. The second observation that we saw is that when it comes to looking at risk prediction, you see what is called as the rate difference between patients who were white versus non-white, in the sense that individuals who were white in the Cornell data set, so the first two columns, were more likely to be diagnosed with postpartum depression. But when we look at the network data set, the rate differences is almost close to zero, right? So in other words, this model is actually performing much better in prediction across this larger data set where there is potentially much more diversity of patients, because Cornell might only get a small segment of New York City population, whereas when you look at Bronx and Brooklyn and Queens and so on, other parts of the city, there is a much more larger catchment, much more diverse patient population, right? So in this case, our rate difference is close to zero, which is what we would like to observe. So in other words, the model is not biasing one racial group versus the other, right? It's performing fairly well across these race groups. One more data point. When we looked at sort of issues around precision and sensitivity, we observed that some of our approaches had higher sensitivity versus the other approach. Now, in this particular case, the goal here is that we want to actually bump up individuals who might be at lower risk so that they can get the appropriate screening, they can get the appropriate treatment, as opposed to only looking at more severely ill patients, right? We, of course, want to flag the severely ill patients, but we also want to look at patients who otherwise might fly under the radar, right? So that it helps the clinicians to make the appropriate decision. So that's a critical decision point that one has to make. And last but not the least here, when we also looked at model that compared a model across the Cornell data versus the research network data sets, we saw that the rate difference, again, as I mentioned, between whites and non-white was close to zero. So that gives us huge amount of confidence that now, maybe finally now, we are at a phase by which we can deploy some of this solution into our routine clinical care, right? But as it turns out, these are not just AI and informatics problems. There's lots of questions around usability testing. There's lots of questions around acceptability of the solutions that come to play. In other words, what happens if the patient sees an AI-generated risk predictor? How should the individual react? Right? In the day and age of open notes, your risk score for depression might be made available to you as a patient before actually you see your physician for your encounter, which might be next week or 2 weeks from now. You might get your risk today. How am I, should I, as the patient, should I take that? Should I accept it? Is it more actually stress-inducing? Does it introduce potential issues around liability? How should clinicians discuss this information with the patients during encounter? What support services are there? So these are, again, very practical implementation science questions that ought to be thought before actually you try to deploy these tools. So what we did in this particular scenario, we tried to actually understand the attitudes broadly for these sets of questions, right? And it goes back to, again, these principles that we have for AI solutions: autonomy, beneficence, justice, trust, privacy, transparency, right? So all of these different axes that we sort of laid out before. And in this particular case, we looked at a small sample of roughly 500 or so individuals, try to understand the general perspectives of use of AI, the comfort in use of AI, what concerns they may have. And then it sort of provides us some objective data when we try to deploy these tools. So what do our results say? This is a small sample, 500 patients. First of all, you can see the top two at the red. A lot of patients were very uncomfortable in having the risk model tell that you have condition X or condition Y, right? In this case, of course, we're looking at serious mental illness as an example, but nonetheless, patients were very concerned. Patients are also concerned if the AI system is recommending a medication, right? They want that to come from the treating physician and the clinician, not the system themselves. So right there, when you are trying to implement a system, when you're recommending intervention, the intervention should be targeted to the clinician, not to the patient. Patient might see a score, but the patient should not necessarily be told that we think you have condition XYZ and you might be diagnosed with this 8 months from now, right? On the other hand, patients were fairly okay in the system saying, recommending general wellness or stress reduction techniques. Please go and do yoga. Please take a walk in the park. Healthy eating habits, healthy sleep hygiene, right? Those were considered to be quote unquote okay for the AI system to actually recommend. So that was an interesting observation. Perhaps not completely surprising, but nonetheless interesting. Then we ask, when we think about the value of AI in mental health, how important it is that the system that can kind of understand the individual risk drivers for a particular condition, right? So we say that, Mrs. Jane Smith, we think that you are at risk of postpartum depression and our confidence is 80%. Is that enough? Or should we also say that we think you have this risk because A, B, C, D, right? You enumerate these conditions. But is that the right thing? The fact that someone has a high BMI, maybe it's a modifiable factor. You can try to do physical activity, bring your weight under control, and so on and so forth. But the fact that someone is a racially ethnic minority, what can you do? You cannot do anything about it, right? So you have to think about, when you even present these risk factors, what are modifiable factors? What are non-modifiable factors? Are non-modifiable factors actually stress-inducing? And as a result, we should not even do anything about it. Should we even show it to clinicians? Because they cannot do anything about it, right? So it introduces all of these types of questions. There's a lot of concerns about how these systems are actually using the data that's being generated with unbeknownst to the individual. And that's a big privacy issue, right? Facebook, Twitter, and so, or X nowadays, Instagram, TikTok, I'm sure all of you are familiar with some of these tools, use your data all the time. You don't know, I don't know, your parents don't know, but they use it all the time. Because what? When you install the app, you quickly skim through the privacy and then click yes, because you want to see the next Insta post, right? Same thing is happening with a lot of these AI solutions. Patients give consent without understanding all the legalese, and there you go. Your data is being used for commercial purposes, and you are potentially paying a price, knowingly or unknowingly. So that's important. We also observed that when it comes to concerns, there was a big set of discussions we had, both in some of our focus groups, as well as this survey about therapeutic relationship. And we talked about this a little bit in our panel today, that the moment you have AI solutions being the front line, being at the front line, and the clinician behind the scenes, is it actually concerning to patients? And it turns out it is. I have a personal relationship with my primary care physician, whom I've known for last 10 years. I can text him, I can call him, and maybe even if it's at 11 p.m. in the night, he's going to pick my phone. I don't want to talk to a chatbot because I don't know the chatbot, right? The chatbot is run by a different company. That company may not exist 2 years from now. So should I give all of my personal information to the chatbot? Perhaps not, right? So there's this trust issue, this therapeutic relationship issue that becomes very, very important. And surprisingly, patients were willing to pay more in this case for, if AI were to be used for mental health care related costs. I'm sure Silicon Valley, likes that particular answer. I'm going to skip through some of the things and just kind of jump into this one very quickly. The other part that's also important from implementation point of view is how actually you present this information, right? So across these, the four rectangles there in your slide, we're presenting the same information, but in different ways. The figure on the left here is only text, right? The top left. The top right, it's text, but plus there is a risk score. Right? We're saying 80% risk. The bottom left, it gives you like a sliding scale, right? Light blue to dark blue. Whereas the bottom right figure shows the same information, but it gives you certain thresholds as well, right? So things that we do not take into account when it comes to like numeracy and numerical literacy around the US population, you have to take all of this into consideration when you're presenting these solutions, especially when you're presenting this in a environment where people may not have English as their first language, people may not have high numeracy skills and numeracy rates, and so all of that becomes important. Right, so we did this study and are continuing to kind of do a lot of this analysis. But bottom line is that when you are trying to design these solutions, it's key to keep in mind what is the primary goal, right? Is my primary goal to inform the clinician about a potential risk? Is my primary goal to inform the patient about a potential risk? Should I inform both the patient and the clinician? What sort of support structure I have in place, right? How should someone perceive these types of risk? All of these are very, very important questions that play a role when it comes to these things, right? So that's sort of, again, the circle here in terms of health systems. And again, we are sort of guided by these principles. And so far, we have spent some time in our work to understand transparency, explainability. We are trying to focus on issues around inclusiveness and equity. We have a lot of work in our group to do around autonomy. And of course, we have not even started looking at questions around responsible and sustainable AI. And this is very important. Otherwise, you will encounter a solution like this, where, how many of you have seen these pictures? How many have heard about this tool called Google Gemini? Okay, so you know that it was a royal failure when they deployed it, because you could go into Google Gemini and say, show me an image of Pope, and it'll show something like this. Or show me an image of a Viking, it'll show image like this, right? Because the system was trained in certain way by which it generated images which are not true, right? Now it is Google, so the CEO of the Google wrote an apology letter and said, well, we tried this, it didn't work out, so please forgive us. You know, can Hospital X say, I'm sorry, my patient, we tried this AI system, it didn't work for you, so please forgive us? No, the stakes are much higher, right? So you know, when we think about the sort of the generative AI hype cycle, we are at the peak of the hype. You hear about ChatGPT and Gen AI every single day, right? While again, Silicon Valley is going to push us more in this direction, I think it's important that we keep sort of the big picture in mind. So with that, I have a couple of recommendations that I'd like to share with you that we completely adhere to. First of all, as we have already discussed, it's absolutely important to conduct robust validation of these models, right? Train, validate, revalidate, revalidate. Absolutely critical. And then try to understand these questions around usability, bias, what vulnerabilities some of these models might have, right? So I think that's recommendation number one. Recommendation number two, it is also absolutely important that there will be bad guys. There will be bad actors who will do bad things, right? So here's an example where, if I can just say you for a second, look at this text here, right? It says patient has a history of back pain and alcohol abuse, and the AI system will flag as opioid abuse risk high. I introduced some noise in the system and replaced back pain with lumbago, which is a term that's synonymous to back pain. And I replaced alcohol abuse with alcohol dependence. Now, the AI system is tricked to think that opioid abuse risk is low, right? So you could think about systems where a hacker is kind of injecting noise all the time into these systems. And as a result, you can have unintended consequences. So as a system, you need to prepare for it, and you need to react proactively, right? Third recommendation, it's absolutely important to think about how these tools could be used by clinicians and by that extension patients, and how it makes their clinical workflow much more efficient. Vinod Khosla, who is a very well-known entrepreneur in Silicon Valley, has this famous quote: machines will replace 80% of doctors in the future. Perhaps to some degree, we have a huge shortage of clinicians in this country and by that extension globally. So clearly, there is a role for how these solutions could potentially help. And what we think that these solutions could really help is by providing educational and training opportunities. We as humans are great at physical interaction, at communication, right? The way I hope I'm able to talk to you today, I can see your body reaction. I cannot do that in a Zoom class, right? So the whole experience is very different. We can express empathy. We can understand reasoning. We're good at that. Systems can go through billions of records at a very short amount of time. They can perform high degree of calculations and things like that. So we have to think about a harmonious relationship. And an important part here is educational and training programs. And last but not the least, we should really use AI to engage in human qualities, right? So things like automating mundane tasks to ease relationship building, at-home monitoring, telemedicine. These are all very, very useful solutions. Here's a picture from a company called Experian, which also generates our FICO scores, or credit scores, sorry. And they are deploying these AI solutions for looking at insurance claims. Once the claim is submitted, there's a high rate of denial and triaging. So they're deploying all of these solutions. And so as a result, the whole idea is that how can computers, and in this case, AI and humans coexist so that collectively they're smarter, right? It's not human versus AI, it's human plus AI. Because the day is not far when AI doctor will see you. It is going to happen. It is happening. It will happen more. There's a fantastic article in The Economist that came out last week. I strongly encourage you to look at it. And I think you'll learn a lot. So with that, I hope you got something out of it. I presented one study out of the 17 different studies that are underway in our group. I'm happy to talk to you offline. Clearly, this is a group effort, so I'm very fortunate to have colleagues both in New York as well as at other places. So if any of this work is of interest to you, and if you like food, so that's a criteria to join my lab. You have to be a foodie, and you have to embrace good food. I big fan of Julia Child there. And if you like this view, send me a note. We are always looking for collaborators. We're always looking for good students to come and do summer internships, rotations, things like that. And my email is right there, very easy to remember. So with that, thank you for your time. We may have a few minutes for questions. Thank you again.
I think we do probably have a quick time for maybe 2 questions, if there are any in the audience. Anyone have a burning question? Yes, you do.
What steps are you going to conduct to make sure that insurance companies won't use your research to nefariously charge individuals higher premiums if they're at risk?
Very, 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 very good question, right? And the short answer is I do not know, at least yet. That's something we are trying to figure out, because insurance companies have access to a lot of information as well, right? And we were again just talking earlier that a lot of these for-profit entities are developing their own AI teams. And unlike in academia where we publish things, right? We have government funding, so we put things out in the open domain. Companies are not obligated to do so, right? Their goal is to benefit their shareholders. And so I think that's a very big debate that's going on. And by some measures like this Coalitions for Health AI, we are engaging the insurance companies to come and talk to us. And to the extent they are willing to talk and share, they are, right? So a lot of this is going to be based on a fabric of trust. And so if they're saying that, well, we are not going to use your data for doing X, Y, Z, you got to trust. Apple says it all the time. Ours is the most secure, yada, yada, yada. And Google's is not. Okay? Do I trust Apple? No, right? So yeah, it's a very thorny issue, very thorny issue.
Time for one more question if someone has one. Well, then I have one. With the polarizing, is there an intersectionality between our political climate and the work that you're doing?
Well, the first good thing is that I think when it comes to the Congress, there is very strong support writ large for biomedical research. And in particularly, I think, especially with the opioid epidemic, I think there is very strong interest in mental health and substance use research. You may be familiar that, at least in the current White House, under the Biden administration, there is a huge agenda broadly around women's health. And so in this country, maternal morbidity and mortality are going up. And so there is a huge push from NIH, from different, from PCORI, from Health Agency of Healthcare Research and Quality. Many governmental organizations are supporting dollars to SAMHSA as well to support improving the situation there. So I think in general, I would like to think that there is stronger support from the government side, and it's less of a bipartisan issue. Could it be different, next year? Highly likely. But the part that I think has been challenging is that a lot of these implementation type work, as an institution, you have to bankroll it to demonstrate preliminary results, and nobody, or very, very hard to get infrastructure money. So institution has to put the money, your down payment, before you can see the ROI. And that's harder to convince. Health system leaders, we're just talking, they have 500 different priorities, and your tiny little research project, is in the basement. So that's where I think there are some challenges there. Yeah. But I remain very optimistic, very optimistic.
All right, let's give our speaker another hand.
Thank you. Thank you so much.
So we want to thank specifically the College of Science for sponsoring or co-sponsoring this event. We would also like to say a special thank you to our Greek partner organizations for welcoming our guests this evening. Our Greek partners are campus leaders who exemplify ethical leadership and have an outstanding commitment to service as the foundation for personal and professional success. Our sorority partner, Delta Phi Lambda Sorority Incorporated, advocates for Asian awareness, empowers women leaders through its values-based programs, and forges everlasting sisterhood through diverse shared experiences. Our fraternity partner, Beta Upsilon Chi, is a national Christian fraternity and exists for the purpose of establishing brotherhood and unity among college men based on the common bond of Jesus Christ. We thank you both for your service this week and your commitment to ethics. Before you leave, we want you to be aware that this does not have to be the last time you engage with the Rutland Institute for Ethics, and we hope that it's actually just the beginning. For students who are with us, your presence tonight brings you one step closer to becoming an ethics scholar. The Distinguished Ethics Scholars Program encourages and recognizes Clemson University students, both undergraduate and graduate, engaged in co-curricular education that is focused on ethics, ethical leadership, and ethical decision-making. The program allows students to earn 1 or 2 scholar designations accompanied by an item to enhance your regalia at graduation. Ethics scholars can earn a graduation cord, and distinguished ethics scholars can earn a graduation medallion. Students will also receive a co-curricular transcript, giving them a competitive edge in the professional interviewing process upon graduation. Information about this program and our events calendar can be found on our website, which is www.clemson.edu/ethics. Or to have all the information at your fingertips, on the back as you exit today, there are QR codes located in the back of the room to connect you to our link tree and follow us on Instagram and LinkedIn. You will get real-time updates about the work of the Institute and opportunities like our TIDE conference as they arise. With that, we appreciate every single one of you being present. I will say that of all of the sessions we have had this week, this is the largest in-person session we have had. And so you are to be congratulated for not only being here, but being an engaging audience. Have a great evening, and please take advantage of the QR codes as you exit. Those of you that have attendance forms, there will be an attendance person that you can hand it to on your way out. Thank you.